Perfect. So without any further delay, I will ask Dr. Lam Ho, who is basically the man behind this virtual workshop, to kick off and to present all the panelists and case presenters.
So, do we start the case now?
Yes, but I think Lam needs to present first everybody.
Yeah,
Okay.
We can just follow the list. Yeah, Merida.
Okay.
Yeah.
Can you see the?
Start with another case, and then you can
Okay.
to work
Okay.
on it.
Yes.
But Lam, I think it would still be nice if you can briefly present all the speakers. Can you show the slide again with all the participants?
The next speaker is Dr. Chui Ga-long. Dr. Chui Ga-long currently works as associate consultant in Prince Wales Hospital. He is a famous operator for coronary intervention and also structural heart. And he had done lots of TAVI, structural, and also PCI in Hong Kong. And for his another interest is OCT. Probably he got the highest volume of OCT in Hong Kong.
Okay, I start share. So can you all see my PowerPoint?
Yes, yes, you can start the slideshow. Yeah.
So good afternoon and good evening, everybody. So my name is KL Chui from Hong Kong. So the case I'm going to present today entitled Unexpected Hypotension After TAVI. So my patient is a 74 years old lady, non-smoker, non-drinker. So she is very thin lady with body weight of only 30 kilogram, and the BMI is only 16.8. And she has past medical history of osteoporosis, chronic rheumatic heart disease with a recurrent admission for heart failure. And the echocardiogram show there is a normal ejection fraction, calcified aortic valve with severe aortic stenosis, moderate aortic regurgitation, moderate to severe MR and severe TR, and there's also severe pulmonary hypertension. So we did the coronary angiogram, which show a normal coronary artery. She was initially referred to the cardiothoracic surgeon for dual valve replacement and tricuspid valve annuloplasty. And although the SDS score is low, but this patient is actually very extreme low body weight with severe cardiac cachexia and frail. So our surgeon concluded that this patient is at prohibited high risk for open heart surgery. Therefore, we arranged a pre-TAVI CT for her, planning for TAVI procedures. So while waiting for the pre-TAVI CT, she was admitted for acute decompensation with cardiogenic shock and pulmonary edema, requiring non-invasive positive pressure ventilation and vasopressor support. So we have to do an urgent BAV with a 80 millimeter true balloon, and patient actually was able to tie over afterwards. So we then performed the pre-TAVI CT for her, and you can see the parameter is 67.9 and suitable for a 26 millimeters Medtronic Everett Pro valve. The access is okay and not much calcium. And the left coronary height is a bit borderline. We're at 10 millimeters, but the left coronary sinus is 34.1, so we think it should be okay. The right coronary height is at 15.8, so we think it's fine for the right side.
Okay. Can I just ask you a short question? The pre-ballooning, mostly you need a quite big sheet for the ballooning. How did you manage the vascular access and the closure? Because you have to do a TAVI afterwards, which can be a problem.
Yeah, just a manual compression.
Okay. Yes.
So because we don't want to close it with like Pogai or dissect the artery and causing subsequent problems. Okay. So I actually stand on, I myself actually manually compress the patient for half an hour. Okay. So this is the CT. So the left coronary height is a bit lowish at 10, right coronary is at okay. Because of the scoliosis, this patient has 2 king in the aorta, but the lumen is adequate and there's not much calcium. So we think it's okay to advance the valve through the groin. So this is the peripheral access, look okay without much calcium. So we put the Everett Pro 26 millimeter valve. So this is the initial deployment, initial attempt. And we think the position was good in first attempt, so we decided to release the valve. Basically is very smooth. And there is some under expansion, and TE show a mild to moderate valvular leak. So we post dilate with a 22 balloon under WOPPER pacing.
Which wire do you use? The W wire?
This is the confident wire come with the Medtronic company. Yes. So because of the ST depression and blood pressure is stable, so we did a non-selective angiogram using the JL 3.5 diagnostic cath. And you can see here is the native aortic valve. It's basically almost covering the left coronary sinus, resulting in subtotal occlusion at the level of the coronary sinus here. So we decided to chimney stent this. So we initially used the JL 3.5 guiding, and we are able to wire the left main through the cell above the left main, and then we insert the balloon, 2O balloon, followed by a guideline insert into the left main, because it increased the deliverability of the tools with the guideliner. And this is the IFS one from the left main. This is the left main. This is at the outside left main, the coronary sinus. You can see actually the native aortic valve leaflet is being pushed up and nearly obstructing the left coronary sinus. This is the native aortic valve leaflet. So I got some still frame images. So this is the native aortic valve. This is aortic wall. So you can see it's actually almost covering all the left coronary sinus. So we insert the stent through with the help of the guideliner being inserted into the left LAD. So it actually this helped to reduce the chance of dislodgement of the stent because passing through the stent, through the struct may cause dislodgement. So we make sure the proximal landing is within the Medtronic heart valve in multiple wheel. And then we deploy this 3.5 times 33 stent, 32 stent in the left coronary. We post dilate with a 5O balloon. And we didn't check with the final IFS. So we are happy with the result. And this is a TEE showing only a trivial paravalvular leak. And there's no regional wall motion abnormality. The ejection fraction is okay. But however, after the wound closure, the blood pressure dropped to 60/30, and the patient become very unstable. And the anesthetist has to inject multiple boluses of adrenaline and also the phenylephrine for the blood pressure. So we have to gain access again. And we ask our colleague to do the TGG again. So this is before, and this is 15 minutes after our post-dilatation. You can see actually there is a hypokinesia over the septum and also the anterior wall. So despite chimney stenting the left coronary, we still have this ischemia causing cardiogenic shock. So we have to go back in. So we do the aortogram. Actually, you can see there is a kinking of the stent.
The kink of the stent, yeah.
Yeah, maybe evidence of some stent fracture. And because of the radial strain probably is not sufficient, and the native valve actually compressed on the stent, causing narrowing of the here. So to rescue this situation, this time we actually use the EBU30 guiding. This is the JY which help to manipulate the guide inside the Medtronic heart valve. So we wire horizontally at the level of the left main by floating the wire inside. So we do some ballooning at the stent, and then we do the IFS. So this is from the left main pullback. You can see in a moment that there is a compression of the stent by the native aortic valve. So this is the left, and you can see that actually the stent is being compressed by the native aortic valve leaflet.
At a certain moment, I saw like 2 layers of stent at the beginning.
Yeah. So we do some ballooning to the stent, and then we decide to put another stent that is more horizontally and coaxially into the left main, because last time the stent is king. So this time we have to do it like more coaxial and horizontally placed stent. So we make sure that the stent is proximal landing is inside the Medtronic heart valve. So we do a rotational angiogram. And we deploy the first 4-5 times 26 stent and repeat the IFUS after post-dilatation with a 5-0 balloon. This time is slightly better. This is from the left main pullback. So you can see that still elliptical, but it's better than last time. So we want to ensure adequate radial strain. So we put the third stent. This is the second stent horizontally placed into the left main. This is the third stent into the left main. So we then post-dilate with the 5-0 balloon, and this is the angiogram result. It's actually 2 stents is able to push the native valve leaflets down because the radial strain is better. So we repeat the IFUS, still elliptical, but the lumen is bigger. And the stent is just inside the heart valve struck. So this is the final result. So a few more slides. So actually, incident of corneal obstruction is not common and usually quoted to be 0.62%, and is more common with balloon expandable valve. And usually 68% of corneal obstruction has a left corneal height of less than 12 millimeters. 70% has sinus of valsalva diameters less than 30. If you are able to rescue with PCI, the 30-day mortality is 22. If you're unsuccessful PCI, you got 100% of mortality. If you rescue with a CABG, then you got half chance survive. So TRIMI stenting is one of the technique. If you have high risk for corneal occlusion, so we usually wire and protect with a stent. So after the valve deployment, so we TRIMI stent from left main all the way to above the STJ. And if you need post-dilatation, you need to do the kissing balloon inflation. However, the long-term result from TRIMI stenting is lacking until recently. There is a TRIMI registry showing 60 cases from 16 centers among 12,000 of TAVR procedures. So TRIMI stenting was performed either due to established corneal artery occlusion or impending corneal artery occlusion. So upfront corneal protection was performed in 70% of patients. So after follow-up of 600 days, only 2 cases of stent failure, 1 ISR and 1 possible late stent thrombosis. So the overall semi-long-term, the medium-term result is fine with TRIMI stenting. So the only predictor of 30-day mortality is whether you do the coronary protection or not. So if you do coronary protection and there is evidence of coronary obstruction after the TAVI, you have less chance of procedure death, 30-day death, MI, and cardiogenic shock. Whereas if you don't do coronary protection and you got coronary occlusion, you got like 50% chance of MI and 20% chance of death. And this is the result, 1-year results after TAVI and TRIMI stenting. So if you do coronary protection, the survival is good. If you don't do coronary protection and there is a coronary artery occlusion, then you got initial mortality and the late result is fine. So in summary, TRIMI stenting has been used to rescue corneal obstruction after TAVI. However, stent kinking or even fracture with inadequate radial strain may still cause problem. So we rescue this complication by placing 2 horizontally aligned overlapping DES, which increase the radial strain to counteract the compression by native aortic valve. So of course, prevention is better. And I think nowadays 3D printing and or even computer simulation may have a role in predicting coronary obstruction and help you decide whether you need to protect with stent or not. So thank you very much for your kind attention. I have to thank Dr. Eugene Wu, Chen Yuho from BOI, who is the referring physician, Ken So, and also the Gary Zhang. So thank you for all.
That's a great case. Thank you. Thank you very much. Basically, my first corneal obstruction after TAVI, I didn't recognize the problem and I lost the patient because you really have to see mostly it's the valve in valve after valve in valve also, but I didn't see after the valve in valve how the leaflet was obstructing and relearning, and it was quite some years ago. We basically had a case 2 days ago also, 3 days ago, where we did the chimney preventively and we needed to do it. So now once you know it and you have seen it, you're aware of that. And quite often also I immediately proceed with putting 2 stents immediately, one in the other, to have more radial force. And of course, as you mentioned, the angle, the way you attack it is very important. It's a great case because I've never seen a kink of a stent for the first time. So I think it's a good moment maybe to have a short discussion. Tito, you're a TAVI interventionist. I see you mentioning something at Basilica, but Basilica is not so easy. And I have seen deadly cases on Basilica, but maybe somebody in the panel wants to comment. Tito, can you put on your phone, on your microphone?
Yeah, I mean, I think it's a great case, and it emphasizes as you highlighted, the importance of recognizing the problem. I think the problem is if you don't recognize it, it's almost universally fatal. I mean, the questions that came to my mind was, at what point do you draw the line to preemptively leave a stent in place? You know what I mean? At 10 millimeters, I would have thought with the wide sinus, you would have been relatively safe. But clearly that didn't happen in this particular case. Normally, we wouldn't leave a stent in place unless it was, 8 millimeters or so.
Yeah, the issues are the right of the sinuses, the way the surgeon has done his work in a valve in valve. The sinuses are really small. The height is very important. I think it's an individual base-to-base decision, but I think now most people preventively put in the guiding, and to be honest, balloon expandables may be a little bit easier to handle than the self-expanding in terms of chimney technique, because you have more space to play. I don't know if you have the same opinion, but although we mostly prefer the balloon expandables for valve and valves. But it's a great case, and you recognized immediately the complication, because hypotension people can think about other potential complications related to TAVI. But if you identified an ischemic cause, that's a great clinical job.
Yeah.
Any more comments? Anybody else?
So you needed more than you had 3 kink stent and 2 other stents. So you have to go through the side. So you increase the challenge for yourself. But so as Eric says, now that you've done this before, is there a preferred stent, and is there a preferred 2 or 3 stents before you leave the case?
Yeah.
Are you doing 2 now, like what Eric does, if you need to chimney stent?
I think it's a really amazing case, and usually we have few experience do TAVI on rheumatic heart disease. Mostly we just do for the valvular heart disease, and I just want, if you have some experience, would you just make a very brief introduction about this?
So because this case has no option and turned down by a surgeon, so and the most severe valve lesion is aortic, so we do the TAVI on her. So for now, I think we need to put maybe at least 2 stents to increase the radial strain, because now the stent is getting thinner and thinner. The radial strain is not severe. I mean, not sufficient.
So there are some stents that can do the job, and some I would definitely not use, but I think everybody knows what we are talking about. We get a sign that we need to move on.
Yes.
Again.
Merida, could you try to share again? Try to sharing the screen.
Yes.
Yeah, great.
Great. I'm sorry my case is not as exciting as the previous one, but it will put us in some important issue during this pandemic state that we have now. Let me see. Where?
Yes,
It
you can start.
You can share as full screen as usual.
Yeah, this is 44 years old male. He was dyslipidemic, obesity, and epilepsy. It was the first day after confinement, after staying home, and he decided to offer a run, not previous training. After 5 minutes, he began with chest pain, but continued his exercise for at least 30 minutes more. When arriving home in bad condition, he called for medical assistance. It's more or less the time that we had. He started at 8 a.m. He arrived home 1 hour later. Night 4 is the first medical contact and the ECG. You can see the ECG here is horrible. It speaks of a proximal LAD. I'm sorry?
He's on the phone. We can continue.
Okay. So I'm going to show you the images just in a second because they can be linked. But in resume, he has cerebral disease. The RCA was dominant with maximum stenosis 90%. The distal left main had no significant lesion. It was an acute proximal occlusion of the LAD. The intermediate branch 90% proximal stenosis, and the left circumflex with a chronic proximal occlusion, and he clinical was on KUEPPER initially. So I'm sorry I have to make it this way, but so this is the right coronary artery. You can see it. It has some severe stenosis, and you already see that the left circumflex, it's not a long vessel, and the right, it's filling the LAD. So this is the next. I'm sorry, I can't see you well. And this is the angio for the left.
Any angiogram right now?
I'm sorry?
You don't see the angio. Can you show the next slide?
Yes. You can see the angio?
No. We only see the description of the angiogram.
Okay. Can you see it now? Can you see it now?
No.
I think video is absent.
The video is not, we don't see any video, no?
No.
You don't see it?
Cannot see.
I'm so sorry. This is... Well, let me see now the video.
If it is a problem, Merida, we can go to the next presenter again, then come back.
Yes, please. Thank you.
Do that. Then you can work quietly on that. Yeah.
Okay. Next presenter is Dr. ISHIHARA.
I think we need to go to the next presenter, and then third time, good best time, like usual. Yeah.
Yeah. Okay.
Who is the next presenter now?
I think it's Dr. ISHIHARA.
Okay.
Good afternoon and good evening.
Yeah.
We move to Japan.
Yes. Can I share my screen?
Yes, sure.
So Merida, you should stop sharing your screen.
Yeah, it's stopped now.
Yeah. Okay. And then we need to get the shared screen.
Can you see my PowerPoints, right?
Yes.
Yes. So I discussed with Dr. Ho, and maybe it is better to share the complication case. So that I will show one very interesting and in other words very terrible case and overseas PCI. So this is the stent migration in left main flank during PCI for RCA CTO. So it's a terrible situation. So as you know, so stent migration is rare complication in new DS era. So these days we don't face often. But once it happens, it is often difficult to retrieve the migrated stent. And donor artery trouble in retrograde PCI is also life-threatening. So I will show one case, and this the patient is 61 years old male, and the culprit region is RCA CTO. And also this is an overseas case in Tunisia. So I don't have enough information of the patient, and I don't know enough background. But ejection fraction is 50%, and creatinine is almost normal. And patient so still so relatively young and also very bigger, so enough healthy patient. So he had a chest pain, so effort chest pain, and also the angiogram showed the moderate stenosis in left main to proximal LAD. Can you see the angio?
Yes, very well.
Yes, okay. And so circumflex is almost okay, but so there's very calcified moderate to in some parts severe stenosis in LAD. So for this case, I try to do PCI for RCA CTO, so that the CTO length is not so long, but it looks very severe calcified. So that I choose retrograde approach from septal branch to RCA to distal RCA. And so first of all, to use septal channel, I dilated the LAD lesion, but it is so severe calcified, so we can see the balloon is not expanded very well. And so during the procedure, so slow flow happened, and hemodynamically very unstable.
Excuse me, may I ask you this case? You see this is triple vessel disease, and RCA has total corrosion now.
Yes.
Very short CTO, and if I do it, and the strategy, maybe I can fix the RCA first, because it looks like maybe quite easy. So why you do the left first? So this is my question. So
yes. I see. So it's a very important point. So RCA, the lesion length is not so long as you say. So it is sometimes very easy. But once if I failed antegrade wiring at that time, so we sometimes need retrograde approach. But for this patient, so LAD have moderate to severe stenosis, left main LAD, so that I just prepare for retrograde approach. And also, and also for this case, so this is overseas case, and it's how can I say so educational situation, so that so local doctor request me to do retrograde approach. So that, of course, so safety is the most important.
Yeah,
but
you like to ensure that you are retrograde the skill.
Yeah.
I can understand, but you told me at the beginning, you say the RCA is corporate lesion, so that we can see that. We can consider the RCA first, because it looks like it's so easy, and maybe it's possible to treat it with integrated approach successfully. So this my thought when I saw you in the beginning when I saw your edgeograph.
Yeah. So
that's your point, Angvin. I think it's clear. But for educational purposes, the complication will be very interesting to share with us. So I suggest you to continue your presentation. And we are not surprised that the patient is unstable.
Yes, I like to see. I like to see.
Yes. So this so maybe do you think this RCA CTO is easy or not? So maybe I will show later how easy or how difficult. So so first of all, I want to fix the left main to LAD lesion, and also the local doctors request me 2, 3, all lesions RCA CTO and also left main to LAD lesion, because so for them this lesion is relatively difficult for the local hospital doctors. So that first of all, so open up with balloon. After that, flow is also okay. And after that, I try to put the stent from for LAD, but stent didn't pass the lesion, so that I open up the calcified lesion again and again, like this. And after that, we decided to put long stent, but it didn't cross left main bifurcation. So during the system retrieval into the guiding catheter, because stent system didn't cross, but at that point stent was stripped out from the delivery balloon, so that we can see the balloon is here, but the stent is still standing at the left main, like this.
Is the stent partially in the guiding or not?
So some part is but the stent. So I will show like this. So stent is totally outside of the guiding catheter. If the proximal part of the stent is inside the guiding, we can trap in the guiding. But unfortunately, stent is so stripped out, and so I couldn't so retrieve into the guiding catheter. So that this so distal part is in the left main, and the proximal part is outside of the guiding catheter.
Okay.
Yes, and in this point, the patient hemodynamic state was very, very unstable. Blood pressure is around 50 to 60. So that I inserted additional guiding catheter, so made 2 guiding systems, because I already prepared for retrograde approach. So I pull out the antegrade guiding catheter, and so insert another left guiding catheter for left coronary, and I open up with a non-compliant valve more harder and harder. So open up like this again and again, and so blood pressure is relatively okay. So 70 to 80 with using inotropes. And after that, I try to put the stent. So unfortunately, I can advance the stent from left main to LAD. So from the second guiding catheter. But as I said, the first stent is already out from the delivery balloon, but I couldn't insert the stent into the guiding catheter. but we have two guiding catheter systems, so that I don't want to lose the migrated stent, so that I put the stent first to fix the hemodynamic state. I want to keep the blood pressure, so that first of all, put the stent here. So the patient condition is relatively better with that. And also the
distal LAD flow is not good.
So
the patient,
I'm sorry?
better. But the patient is better because the distal LAD flow is not so good.
Yes, yes. So this is a the situation. So this is a first guiding catheter, and the stent is migrated here. So, but still on the guide wire. And also, this is second guiding catheter. I put the stent so that this wire, stent is on the wire. If how can I say, trapped with the stent, but it's not. It's okay because wire might be easily pulled back, and also here we can see the stent. So maybe it is easy to catch the stent by snare or something.
Is there a balloon in the stent because the stent looks like expanded?
I try to pull back this stent into the guiding catheter using small balloon. I put the 1.2 balloon and so relatively inflate and pull back the balloon with the stent, but the stent couldn't. I couldn't retrieve the stent. It is so how can I say? It hits the guiding catheter tip, so it's totally difficult. And already, so proximal part is broken. So
did you not consider to put the stent more down for the safe side to avoid it migrating to the brain, or just put it in the abdominal aorta, the whole thing?
Yes. So more pull back, and so maybe it makes coaxial or something. Yes, but in this situation, so if we have the snare, it's easy to catch this stent. So like this, okay, we can literally with snare, and also this stent is on the wire, and the wire, distal part of the wire is oppressed with the stent, so that we don't lose this stent. Just so stent is on the rail, so it's easy. I consider like this, but this is overseas country and the snare is unavailable. And so still guide wire is in here, and I can advance wire or something. And if this stent proximal part is entered into the guiding catheter, we can trap, we can catch with balloon or something, but it's totally difficult. And snare is not unavailable. What? Oh my God! What?
So what can we do? Somebody have some idea?
Yes. So
Sidney, do you have an idea, a proposal?
I think Dr. Sumasuji has a way of making a snare with a balloon and a wire.
Yes.
You can also use a long wire, basically a long 360 wire, and a big guiding catheter, and just loop it, and you can make a pseudo snare as well.
Yeah, some wires may break, but you can use indeed a long wire and then just make a band.
Yeah.
And what I would consider also is using the other guiding, if it's from the opposite side, and then to snare it with the once the left main is dilated and the thing is treated, you can use the opposite guiding, which maybe snare easier. Maybe just an idea, I guess. I've never done it.
Yes.
Okay,
so,
let's continue. Show us what you did.
Yes. I know. I know self-made snare. So I try to use self-made snare. So using guided extension catheter and also wire and also balloon. But unfortunately, for this guiding catheter and with this wire, so I couldn't enter the self-made snare. It's totally difficult. So that so I'm considering what I can do. At that point, local doctor said, okay, we have forceps for gallstone. I haven't used like this one. So it's for gallstone. So maybe not for coronary. So can I use this one? But so the local doctor brought me. So I tried. So I started out. It's total. So it's very it's first time for you. But fortunately, it can catch the stent, and also we can retrieve the stent into the guiding catheter. And fortunately, it was retrieved. After that, I put the additional stent and performed kissing balloon stent, and fortunately, left coronary is so nicely treated. In this situation, so patient condition is very nice. So what I can do? Can I do retrograde from septal? Can I do antegrade? So it takes maybe more than 2 hours, and so patient was a little bit tired. So that I started RCA CTO again with antegrade. So fortunately, the guide wire easily crossed the CTO region from antegrade, and put the stent, and the final result is very nice. Yes. So so retrieval of the migrated stent is so of course. So we can see snare and sometimes tangled guide wire. So it's called wire twist technique. Must be effective, and also we if possible we can change the larger guiding catheter and additional puncture and double guiding catheter, as I said, as I done, and also consider to implant other dislodged place or proximal part if it is safe. It's considerable. And after guide wire is pulled out and unable to dilate the stent from inside, so we sometimes put the stent at the point, and we can deploy another stent and crush at the place. It's one solution. If snare is unavailable, forceps might be effective in some situation. I have never heard using this kind of device for retrieving some broken device. So what is the point we learn from this case? So maybe first of all, double guiding catheter system is very important, and also full use of available devices. Even it's never seen. Is also one option, and also never give up. So if we treat donor artery for the retrograde approach, we should pay attention for hemodynamic risk, and also don't make so complication. Operator should prepare better techniques in case of stent migration. So thank you for your attention.
Thank you so much.
Thank you.
So the old teaching is that devices are removed en bloc, as Erica alluded to. So you can remove the guiding catheter wire and the stent down distally, but I think it might fly off because it was loose. And so you may almost once you stent it with the other guiding catheter and you stent the left main more stable, you could relinquish the wire access to it from the other guide, upsize the guiding catheter, because sometimes you have trouble retrieving it if you're using that to snare the stent. Once you secure the stent in the other guiding catheter, which may be 8 French or 9 French or bigger, because it's sometimes a lot easier to do that. But anyway, in this case, Zhang Bin was right. Do the right first.
Yeah, but anyway, we learned something. The other thing is that if you are doing this in a foreign hospital in another country, you know, if you don't have anything, just pull the whole thing down up to the abdominal aorta, and then just rip off the stent somewhere at the femoral level. And you know how many stents we left in the peripheral circulation 20, 50 years ago. So just leave it there. Nothing happens mostly. So in case you're in trouble and you don't have any material, don't forget that just, I'm not saying it's the best solution, but it's certainly the best of the worst. That don't forget that you can just leave non-deployed stent. Rarely, I've never seen something happen.
It's a worst case. It's probably the worst safe scenario because I've seen people trying to snare. You can deform the stent. You can actually occlude distal peripheral vessels. You can make it a lot worse. Or if you're doing radial case, you get trapped in the radial artery and cause damage as well.
That's another animal. But in the femoral, just leave it in. Nothing can be done, just leave it there. Rather than getting complications related to trying to put it out. Okay, Lam, great. The
next one is Tito.
Tito, and then Merida, how are your videos?
I think Tito can go on. I will try again. I had done it, but
okay, let's go.
Maybe we let Tito.
Yes.
Tito.
Yes.
So we go to London now.
Yeah,
I'm just to
share my screen. Where are we? PowerPoint. Here we go. Security, preferences. Just okay. Bear with me just a second. It's asking for access to share this. Sorry. Okay. Hopefully that's done. And I'm just going to reopen it.
I had a great complication yesterday.
You did?
Yes, incredible.
What it was about?
Just to this forum?
I can tell it in 1 minute, but let Tito go on first.
Tito, can you share the screen?
Yeah. Finding Zoom.
Okay.
Asking for preference when I system preference.
Just one follow-up to the last case. I mean, it was a great save and it was a great case, and it was all due to this operator's experience that he managed to save and retrieve the stent. But I mean, let's think about the reason why he lost the stent. It's a lot. Well, we have to think about the treatment strategies and look at diffuse calcifies coronary arteries, and I think there was the problem that maybe the approach was a little bit too enthusiastic to go forward.
Dr. ISHIHARA knows that. He knows that. He knows definitely that.
I know.
Yeah.
That's the main issue that we always have to be aware and be humble and try to think ahead.
We got another complication. I think Dr. Tito is offline because of some network problem. Maybe we proceed with another.
I can
next speaker.
1 minute if you want, while we're waiting for Tito. Yeah. It's really incredible. I can tell it like this because we don't need videos. How far are you, Tito? Or is he offline?
He's offline.
So yeah, so 2 days ago. Are we going with the next one?
No, you tell me your story.
So the story is crazy. It's a 32-year-old lady. She's a very famous lady in Switzerland. Tito is there. Okay.
Yeah.
Let's go.
Sorry, apologies. I didn't realize you had to get you change your security settings to share the screen with Zoom. But okay, your story sounded more interesting than my case, I have to say.
I'll continue afterwards.
Okay, well, thank you, Lam Ho, for organizing and inviting, and thank you for this opportunity. So the case I wanted to present was just a bit of background. 61-year-old gentleman who arrived from Nigeria with chest pain, short of breath during the flight, and had chest pain on and off for the weeks prior to the procedure, had ST depression, and was subsequently found to be troponin positive. He had a background of hypertension, hypercholesterolemia, and malaria. And essentially, on arrival, one of my colleagues carried out a coronary angiogram, and the next slide is going to play the angiogram just for your background. So this is the angiogram, and it's an AVI. It's going to run through the different views. So you can see the left main stem up until the distal end is relatively spared, but the severe diffuse extensive disease along the LAD and the circumflex. As you're about to see, once the angiogram is performed, there's essentially a CTO of the right coronary artery. Yeah, there you go.
Mm-hmm.
So my colleague decided to stop at that point and ask for a cardiothoracic opinion. Incidentally, would anyone have taken that on at that point?
Of course, you always have to consider it. Huh?
Yeah, I mean, I have to say, I suspect his pain was waxing and waning, and that's why he stopped. There are some issues that are relevant in that he was ineligible for NHS treatment and didn't have insurance. However, even our hard-nosed administrators agreed to offer this gentleman treatment. His initial hemoglobin was a little bit low, renal function was normal, and he was negative for COVID. His echocardiogram demonstrated a severely impaired LV with mild mitral regurgitation. And he subsequently went on to have an MRI scan, which, the long and the short of it is that the LAD and the circumflex territory were viable, whereas the majority of the right, or a significant bit of the right, was felt not to be significant. Whilst he was in hospital, developed a pancytopenia and was found to have splenomegaly, and then underwent a variety of tests, which is ultimately put down to him having contracted a CMV infection. He was discussed, I don't know whether this is the same experience everywhere else, but the COVID pandemic seems to have increased the potential for Zoom MDTs. And we have an MDT essentially every day for any case that is relatively complicated. And he had a discussion, and the conclusion was the surgeons weren't going to operate on him, but we offered him PCI because of the ongoing symptoms intermittently and the anatomy. So really, I'd just like to throw it open to just for a few seconds. I don't know, any thoughts on how you'd approach that? Eric?
Maybe we can ask Zanbin, maybe.
Yep.
Is there?
I mean, just via AD, via circumflex, and just PCI. Seems there's some aneurysm, but so maybe it's okay after stenting.
Yeah. So
the problem is post PCI antiplatelet issue.
People ask
yeah.
Angio again. People, can you show the angio again?
Yeah. Let me go back. There you go. Hold on.
Mostly the left. That's what we need to see.
Yeah.
We don't see the collaterals to the right very well.
Yeah, I think the MRI would suggest that the right wasn't worth chasing, and I didn't chase the right. So what I did do was I went with an impeller.
Mm-hmm.
And I did that because essentially all three of his vessels were severely diseased and his ejection fraction was very low. I don't know, would other people have done that or not? But I used
for the hospital, but yeah.
Yeah, it's a very reasonable thing. It's very expensive.
I know, but I think we were in a situation where either we did nothing or we did something, and we'd rather he didn't die on the table. So we went with the impeller, and this was all discussed at the MDT. And that's one of the benefits of the MDT, I guess, that you know, people hopefully won't quibble afterwards. We can blame it on the collective decision, I guess. We went with an impeller. Well, I went with an impeller, and I don't know whether most people are doing this or not, or it's commonplace, but we went with a single access technique using a 7 French radial sheath through the initial peel away sheath and just left the peel away sheath in place, but with a 7 French radial sheath through the sort of the sort of rubber windows, as it were. And then I used a 7 French guide. It's at this point, I mean, I usually sort of in a rather offhand manner ask, are we sure that the patient is on antiplatelet medication? We discovered that the patient wasn't on any antiplatelets other than aspirin. So despite his pancytopenia, I gave him Cangrelor and an oral dose of clopidogrel and carried on. It was either that or stop. So we continued. And the strategy I used, I suspect, I'm not sure that everyone would have used, and that's maybe will open the discussion. So I wired both, just as Lam was saying, and I dilated everything with a combination of 2.5 and 3 millimeter Scoreflex balloons in the proximal 2/3 of both vessels. And then I used IVUS to assess the vessels. And I concluded from that the vessels were heavily calcified, and also that the diameter really was much larger than initially I had estimated. And these were essentially 4 millimeter vessels. You could probably have predicted that from the circ.
Shockwave balloon as well.
Well, exactly. You're exactly right, and that's what I did. I went to increase the cost even further and shockwaved the proximal 2/3 of both of the vessels along the proximal 2/3, I guess, of both vessels, and then this is a sort of post shockwave and Scoreflex ballooning treatment. Obviously, there's been some recoil angiographically, but on IVUS, the calcium was cracked at various points. So what strategy would people go for here?
A lot of stents, probably, for sure.
Yeah, I mean, my questions. I mean,
you wouldn't skim now. You wouldn't skim now. The question's stent expansion. So you could, if you can get it cracked up, then you just stent everything. I mean, you have a two-stent strategy. I'm not sure, whichever you're comfortable with doing, getting good result, essentially. Yeah. So if you're already, yeah.
And I think you're going to end up, the left main bifurcation is going to be the issue because you're not stopping any of those stents at the ostium. So.
Well, that's very pertinent of you. That's more or less what I did. And I did this because I thought the discrepancy between the vessel size and the left main was huge. I mean, the left main was 8. And the vessels were 4. And I just didn't believe I was going to get a stent to touch the sides properly. I mean, I would try, of course. So what I did was I deployed 4x38 Promus in each of the vessels, coming back to the ostium. And in fact, I think the circ probably was just into the left main. Maybe one, it looks worse than it is there, but because the vessel kind of folds over a little bit at the bifurcation. And then I postulated the whole lot with non-compliant balloons to high pressure and essentially kissed back into the left main stem without actually stenting the left main stem. And my provisional plan was to, if needs be, if I dissected the left main, to then drop a stent in a large stent, or as large as I could find, in the left main to the bifurcation and some sort of Y shape of 3 stents. And I IVUSed it. Apologies, I don't have the IVUS images here, but the IVUS images were highly reassuring. Apart from that sort of aneurysmal circumflex segment. And that's how I left it. And he did actually very, very well.
How did the impeller perform, Tito? You just kept it on all the way, or?
Yeah, so I left the impeller on throughout the whole procedure. Whenever I ballooned any of his vessels, the pulse pressure just narrowed. You know, when you have the impeller in place, it kind of gives you this security blanket. When you're ballooning it, you can see the pulse pressure just narrows to 5 or 10 millimeters, and then it picks up after 20, 30 seconds. And almost certainly, if you didn't have the impeller at that stage, his blood pressure would have been, quite significantly impaired. And I guess there would be a question mark of whether it would have come back up or not. I mean, in those situations without the impeller, I guess most of us, I would have given some sort of small bolus of adrenaline. But with the impeller, there wasn't really a need for that. And that was the final result. I debated in my mind whether or not to tackle the distal disease in the LAD. I didn't feel like stenting it right the way to the apex or close to the apex. I just left that, and I thought I treated the proximal 2/3, and that would probably keep this gentleman alive and well, at least in the first instance, and take it from there. I don't know what other people would have done.
Well, I think it's quite valuable. Huh? How many stents in total, Tito?
Just two. Two.
Wow.
4x38 squared. Yeah. Just posted later than with 4 non-compliant balloons. I think his anatomy gave me the belief that I could get away with that, and the IVUS images afterwards essentially confirmed that. I just stented right as far as I could to the ostium, and maybe there was one strut with a circumflex leading into the left main, but all the disease was covered. And that was it. I took everything out, 2 proglides, left him on heart failure medications. Interestingly, his pancytopenia normalized, and he was discharged very well. Obviously, his LV, what happens to his LV remains to be seen. But that's it.
Because the MRI showed that there is really room for a heart for his LV function to improve. Huh?
Yeah, I mean, I have to say that I probably would repeat the MRI after an interval and consider the CTO of the right, because I don't know what everyone else's experience is, but quite often the CT, the MRI, when somebody's acutely unwell, can be confounding. I think there could be edema and things which confound it. I'm not an MRI expert.
The only thing we don't see a lot of collateral flow to the right. That's the only thing. Maybe it's because the quality is not so good, but
yeah, there are septals. I agree, Eric. There aren't the best images, but in some of the views you can see LAD septal collaterals.
Okay.
Would anyone have done the right CTO at the same time?
I think our Asian colleagues will all say yes.
Yeah, of course.
It's a great job. So I think regardless, it's a fantastic job. Depends on whether you spend 2 hours doing it if it was difficult. So
my baseline position would be to stage that.
Yeah, of course. No, you certainly not do it only already for all the contrast load that you will use. You don't need the impeller for the CTO.
No, hopefully not. No.
I think the problem is usually if he's still bad and you're coming in to stage it, then you wouldn't put a second impeller in. So, if you didn't use a lot of contrast, you might want to do it now because you can't afford another impeller.
Yes. Okay. Who will be the next presenter?
Who is the next presenter? How is Merida doing?
Merida,
it seems that finally I'm going to be able.
Okay.
Let me see. Let me see.
So Merida, you're in the south of Spain where the COVID situation is better than the rest of the country, yeah?
Yeah. Unfortunately, we have other problems. Can you see me now?
Yes, Andrew, yeah.
Yeah, so as I told you before, can you see the image now?
We see a still frame.
Yes.
Yes, can you see the angel?
Yeah, but you need to run it.
Great. So if you don't mind, I will rather speak than show you the slides because the images are not well linked. So this gentleman was 44 years old, as I told you before. He was overweight and epilepsy. He had no history or previous cardiovascular disease. And he was confined during this whole time for how many weeks? I don't recall them well. So it was the first day that it was by the government. We were allowed to go out and do some exercise. So this gentleman took it seriously. So he put his sneakers and went out. Just at the first 5 minutes, he began with chest pain, but he continued until 30 minutes more. After that, he was in a regular condition that got worse, so he called for emergencies. And as I show you, the ECG was a right bundle branch block and also an ST segment in the anterior wall. So this is the right coronary artery. You can see here that it has some severe disease. And then you have the left that it, as you can see, it can only open this intermedial branch, and the rest is the chronic occlusion of the circumflex, looks like, and the acute occlusion of the LAD.
And you show it in
the image is still, can you
push the play button? On the
you
left
can see it.
upper side, yeah, you just, on the left upper side, you have the play button. If you put it on, and you can see the it's moving.
Can you see it?
Yes, but you need to run it. It's a fixed image.
I know, it has to be running. Okay.
Push on the play
Can you
button.
see it now? It's running.
It's fixed.
Okay. Let me see if this one is running. Everyone. Oh God.
Oh God.
It's a complication.
Yeah.
Is it running now because it's running on my PC? No. Okay, let me try.
And open it again.
Okay, let's see.
Okay.
Okay.
Yeah. Those complications always occur. I see a message. Dr. Jiu, he want to present first because he had an emergency PCIs. Why?
Hello, everybody. I'm so nice to be here with you. Because I just received an emergency call from hospital. I have an emergency apparent PCI. So
maybe we can join you on the trip to the hospital and see your case live.
Yeah. So with your permission, I like to share my case. It's really my honor to be here to share my case. And I have a sorry case both for left main bifurcation case. And the first case, a 66 years old gentleman, for chest pain for 1 year and recurrent chest pain for 2 months, disease factor, hypertension, and dyslipidemia. And the physical examination and echo both normal. And let's see the angio. We can see it clearly. The left main bifurcation case here is it's very it's very complicated bifurcation case. It's very hard to put wire into the LAD. So first I use wire into the circumflex and also another wire to the remus. And I want to put the third wire into the LAD, but it's really very hard because it's the angle is very tough angle. So we use reverse wire bending technique and with the accessment of KDR catheter. You can see like this. Okay. So when we put the wire into the LAD and just we use balloon to predilation the left main to LAD, and then we do the IVUS check. Okay, and the IVUS show the placar located on the LAD side, but the circumflex ostium of circumflex is okay. So no any very the placar. So we use the crossover stent technique, only one stent from left main to LAD, and this is post dilation. And we can see the final result is okay. Now, this final result, and after 12 months, we ask the patient back to do the angio follow-up. The stent is okay, and also the circumflex and the bifurcation, the remus is okay. So the first case and second case, also 45 years old gentleman, chest pain for 2 years and examined for 1 week. The coronary CT indicated severe left main and proximal LAD and proximal subflex stenosis. So the risk factor of this patient is dyslipidemia and stroke. Also, the echo is normal. So we can see from the angiograph, we can see the distal left main is very serious stenosis. Also, the ostium of LAD and the ostium of subflex are very serious stenosis. And but here is at the angle. And the original for LED is also a very tough angle. It's very hard to use put wire into the LED. So first we put, you can see it's a tough angle. From here, like this, but not directly into the LED. So we put wire into the subflex, also use the reverse bending wire technique, into the LED. And then we do after this, because the carina is like this, so we want to, if put stent like from LED to left main, maybe I think the ostium of subflex will be jailed. So we use two stent. It's a mini cross stent technique. It's the first stent in subflex and the second stent in LED to left main. So after this we do the final casing and also the POT technique, and this is the final result. So you can see this is the final result. Also the patient is okay. The third case is 66 years old gentleman, chest pain for 3 years and a recurrent chest pain for 1 month. Also in 2016 angiography showed distal left mains 18% stenosis and proximal LAD is 90% stenosis. And at that time, the PCI to left main to LAD is 2 stent and the recurrent F of chest pain for 1 month. So the risk factors hypertension and dyslipidemia and diabetes and all stroke. So we can see like this. Okay, here so everything left main to LED is okay, but very big reamers is very serious stenosis in ostium. So it's very dilemma situation, because if you only to deal with the with stent, maybe the LAD to stent to the left main will affect it. So it's very hard to make the strategy. So at that time, I use a cutting balloon. I use a balloon to dilate the reamers, and then use a cutting balloon like this. It's 3.5 cutting balloon to cutting the ostium of reamers. So after this is okay. Then we use a drug coating balloon to treat the reamers. Okay, this is the final result. Also, the patient after 10 months follow-up, the ostium of reamers is okay. So this is the third case. And also the fourth case is a 45 years old gentleman, chest discomfort for 3 years. Also the angiography found left main, the triple disease with severe calcification. It's also 3 years before in Hong Kong. Also the complication, the complaint aggravated after chest pain for 3 months. Okay. And the exercise ECG is positive. So risk factors, hypertension, dyslipidemia, and also is an ex-smoker. And we can see from the angiography, the distal of left main is very serious stenosis, and also the most, I think the most most challenging is for this case is very, very tortuous left main to LAD, and also very severe calcification. So at the first time, I don't want to touch this case because there is very a challenging case. So okay, here is we can from a spinal position, and also the right coronary artery is okay. And I want to find some reason for me to leave it alone. So I use the FFR to test the stenosis, but the FFR is 0.58. At first, I want to find a reason for me to not touch this case, but finally, I had to. to do this case, because FFR is really low. So because here is a very serious stenosis and also very heavily calcificated, it's from the IVUS, we can see it's really calcificated with almost 360 calcificated. So we use rotablation, and it's 1.5 millimeter burr, and for many times to rotablation in this case. And after this, we put stent from LAD to left main. So, and also it's used crossover stent technique. And after stenting, we use post dilation and the POT technique. So we can see the result is okay. Also, the whole stent is well positioned and expanded good. So also the side branch is open. So, and also after the operation, we check FFR again, is 0.83, so it's okay. And this the final result of this patient. Okay, so use Western technique. And the fifth case is 61 years old gentleman, also recurrent chest pain for 1 month. We can see the angiography. You can see the ostium of left main is very serious stenosis, and also the proximal part of LAD have some lesion, and also the ostium for subflex is very serious. But the biggest problem of the patient is the left main is very, very short. It's very short, so it's very hard to make a I think make a strategy for this patient, and also it's complaint very you know, the chest pain. So we can see from here it's very short left main. Yes. And so I want to do the left main case, and so I use EBU 3.5 guiding catheter. But now you can see the pressure is down, and also the contrast doesn't flow in, because it's a very serious stenosis in the ostium of left main. Then I floating the wire into the LAD and floating the wire into subflex, and then I drop the guiding catheter out of the left main ostium, and the pressure is okay. So I use because for this patient, the left main is very, very short. So I want to use I want to mate left main. So I use QLOT technique. This first I use balloon to dilate subflex and dilate left main to LAD. Then I put stent into the subflex to the left main, and after this I just you know, the rewiring the wire, retrieve the wire from left the subflex, and then rewiring from the first very first the network to the LAD. So then after rewiring to the LAD, and then I put a stent from left main to LAD, and then do the final casing, and it's a mini culotte stent technique. Okay, to do this. So this I think the last case also bifurcation case, but it's really a bad example. This case is a 54 years old gentleman, and he's recurrent chest pain for 1 month. Also, the patient had respect with hypertension and dyslipidemia. Also, the echo was normal. It's a 5 years case. 5 years case. We can see from the angiography, it's really serious stenosis in the left main and also the proximal part of LAD. Because you know, at that time the Cordis have a new guiding catheter, which means XB. They want me to try this new guiding catheter. At that time, one of my fellow want to do this case. I think, okay, you can operate, but you know, you can see from the guiding catheter make a very, very big complication. from the left main to the sinus, make a very big, after the injection, make a very big complication. Okay, dissection. Yes, dissection. Oops. At that time, the patient just the blood pressure drop, and also the patient complain chest pain. Then I run into the cath lab, and I draw out the new guiding catheter and throw it away. Then I need a new guiding catheter, but the guiding catheter must be a very, very good backup, because the patient very a little calcification of the coronary artery, also has some tortuous layer. So I need a good backup guiding catheter. So I choose EBU 3.5 guiding catheter. And also I use a wire to floating into the LAD. Then I floating the wire into the subflex. The first try, you can see the wire into the subintimal. But after try again, it's successfully floating to the LAD. At that time, when I just floating the wire, the patient just got ventricular fibrillation. Then I use the defibrillation. The patient just recovered. I use balloon to dilate from LAD to left main, and also dilate from subflex to left main. Then the patient's condition getting stable. So at that time, because the LAD is smaller, but the subflex is much more bigger than LAD. Then I use the inverted mini crush. The subflex to LAD, we consider it as the main branch. Also LAD is the side branch. Okay, it's a mini crush. Okay, it's a pot. It's the final result is okay. Also all cover the dissection. So the bifurcation, we have before we made the strategy, I think we need to consider the location, the classification of the left main bifurcation, and also the placar distribution, and also diameter of the main branch and side branch, also the bifurcation angle. And also we need to consider the carina shift. I draw this like this. I think everybody is very familiar, so I don't.
We can skip this.
Yeah. So we do some summaries. This is the first case because because the placar distribution is only in the LAD side, so we use the one stent technique. And also the second, because of the placar distribution and carina shift, we use two stent technique, the mini crush. And the third case, because we consider the placar distribution and also diameter of the mid branch and the side branch, we only use DCB, cutting balloon and DCB technique. Also the fourth case, we consider the placar distribution and the placar characteristics, also diameter of the main branch and side branch. We use one stent techniques, is crossover technique. Also the fifth case, we consider the location and the placar distribution. Also, it's very, very short left main, so we use mini culotte two stent technique. Okay, so thank you, everybody.
Okay, thank you very much. So that was a colleague from Beijing. So the first case is always a little bit tricky, of course. If you balloon without wire access, we know that mostly it works because you balloon, and then it's mostly easier to go into this vessel. But sometimes it doesn't work. Huh? So it's very courageous of you. I can show you on something we sometimes use is the supercross. I can just show it here. This is this angled.
Yes.
You see it? This angled microcatheter. It's quite nice to use. Sometimes it has different shapes. It goes from 45, 90, 1. So sometimes it's quite useful microcatheter. It's from Teleflex company. Anybody else has an experience with the supercross? Sidney, I think you must have experience with that, or Tito, from this supercross.
Yeah, I've used it. It depends on the angulation. It can be a good tool. The other thing I've used is in this sort of circuit, a dual lumen catheter with a shepherd's crook on it.
Yeah.
A little bit like the reverse wiring that you mentioned, but just with the facilitation of the dual lumen catheter.
Yeah. I use it a few times, not very often, but it can be very helpful. And any thoughts? Anybody? Any thoughts on ballooning a side branch before going into a main, because helping that, or you're hoping that it will be easier to access the difficult angled main vessel? Tito, have you done that on occasion?
Very, very rarely, but I think it's a very high risk strategy because you could quite easily.
Because it was the LED, yeah. But it worked, and yeah, of course. On the other side, we have now so good wires. I think everybody that are so workable, and that that are really excellent in terms of
this. A parallel question to this would be, if you've got horrible calcific distal left main disease involving both branches, and you have to rotablate, you have traditionally you have to take the wire out of the other vessel to rotablate, say, for example, towards the LAD. You remove the wire from the circumflex. That can also be a little bit nerve-wracking, but also usually works out somehow.
Yeah, we shouldn't forget surgery if it's really, really complicated and delicate. Okay, thank you very much for your presentation. Lam, who will be the next? How is Merida doing? Is it a lost case, Merida, your presentation, or how are you?
Yes, we can. Hopefully.
For try.
Okay.
After you, it will be Dave from South Africa who will present.
Okay, let me see if it's working now. Okay, can you see it running now?
Not yet.
Oh, goodness.
The patient was running, we know that.
Okay.
Let's stop running.
No, it's not running. You go on with another case and then I'll go back again.
Dave, are you ready?
Yep. I can try share screen.
Yes.
I did. I tried to share screen. I tried to share everything, but it's not running the video.
Let's go meet with Dave and then we'll see how we can.
Okay.
Can you see that?
Yes, we see.
Yes.
Okay.
Yeah.
But
Tito, this one's for you based on your last comment. Thanks for the honor of showing a case in this company. I greatly appreciate it. Thanks for the invitation. Maybe a simple case to compare to some of those we've seen already. But let me tell you about this patient. There was a personal aspect to this patient. I tell you, he's a 75-year-old retired school teacher and a priest. In fact, he was my school teacher 30 years ago, which always makes these kind of cases just a little bit more complicated. And he's got an AVR, 1984, very compliant with warfarin, never had a valve complication for all those years. And I started seeing him in about 2000, long-standing hypertension. Incidentally, I found him to be in atrial fibrillation when he came for his sort of 18-monthly check in 2017. And he presented to our hospital with crescendo angina, non-ST elevation ACS, ongoing critical ischemia. We had him on a nitrate infusion in CCU. He had diffuse multi-lead ST segment depression, and an echo in the unit showed that he had anteroapical apicoceptal hypokinesia. He had a preserved EF. He had a very well-functioning bileaflet valve, and he had calcium everywhere, extreme mitral calcification, dilated aortic root with calcium, and the aorta was 46 millimeters dimension just above the valve. His creatinine was reasonable. So these are angios. Are they playing for you?
Yes. Oh my God.
So there's a lot to see on here. You can see that he's got a you can just see over the circumflex there that he's got a bileaflet valve that's working well. You can see that he's got a sort of porcelain aorta. You can also see that apart from the obvious, extremely calcified left main bifurcation, he's got a critical calcified lesion in the proximal circumflex, very eccentric, almost spiral looking. And then in mid-LAD, there's almost a subtotal, extremely calcified lesion, and his coronary arteries are sort of almost fossilized. Interesting, I'm doing him femoral here because I didn't have a catheter that would reach his left mainstem for the initial diagnostic films. It was very difficult in this aorta to get close. So at the right coronary artery, I'm not showing you, it was vestigial and completely occluded. It was of no consequence. So he has no right coronary at all. This is his coronary circulation. You can see the lesion very nicely here in the circumflex. This almost, and then the huge blobs of calcium in the left main.
Or is the left main okay, Dave? Because it's difficult to see from here. There is something.
Oh, you're not. The left main is extremely calcified, 99% occluded, really.
Okay.
It tapers to a distal point.
Okay.
So, having looked at that aorta, we sent him for a chest CT, and it's got a very significant aorta with extensive circumferential calcification, extensive massive coronary calcification, and the CT guys described it as a porcelain aorta, which of course is a red flag for any cardiac surgeon. So for us, there was a lot of challenges here. Deal with the calcium, deal with the left mainstem bifurcation and critical calcified lesions in both main trunks more distally. And so there was a lot to discuss, and maybe we'll hear some contributions as we go, but I'll show you what we did. It was an immediate surgical turndown. Our surgeon said he thought that really the risk of redo surgery in a 76-year-old man with a porcelain aorta, pre-existing valve and a critical left main, he felt that the risk was really very, very high for redo surgery.
Right. You're absolutely right.
So I think this was a case of caught between literally a rock and a hard place. And so what I decided to do, this is a EBU 5 7 French catheter from the radial position. Can you see the left main in that view, Eric?
Yes, very clear. Better now, yeah.
And I decided that we would wire, the circumflex was very easy to wire, and I decided to go for the circumflex first to deal with this very severe lesion, knowing that also we had to still deal with the mid-LAD lesion as well. So we wrote it with a 1.75 burr. Both the left main, the distal left main, as well easily past the other lesion in the circumflex. We went right down into the second lesion, and it didn't offer much resistance with a 1.75 burr.
There is comment on lithotripsy, but this is not the first line option. A lithotripsy balloon will never cross this lesion. I think so. Huh? That's my humble opinion.
So yeah, that was one point for discussion. I mean, we didn't have lithotripsy available, still don't. In fact, we're struggling with approvals and funders and whatnot. So yeah, I was stuck with rotablator. And that was after, fortunately, as Tito spoke about earlier, the LAD flow was maintained as we went for the circumflex. And then having rotated that, I decided to go for the LAD. Now here you can see this extreme calcified lesion in the LAD. Well, the whole LAD is calcified, but this lesion, really a terrible lesion. And to my surprise, it was very easily wired. Without too much difficulty. I think it was a cyan blue wire, in fact, that I'd used for the circumflex. I managed to maneuver it through there without too much difficulty. But that was where the problem started, because after attempting to do every technique that I know to get a rotor wire down there, I could not get a rotor wire down there with multiple support catheters. I also couldn't cross with a 0.8 Nick Nano, and in the meantime, this patient, has just had rotor to the left main bifurcation, and requiring repeated boluses of phenol to keep his blood pressure up. And remember, he was my school teacher. Huh? So
you're exchanging with a microcatheter, Dave.
Yeah, so I used a number of microcatheters, and even, you know, wedging the microcatheter into the lesion and trying to get a rotor floppy, I was just unable. It took me a long time. And after about 30 minutes, I decided, look, this is, you know, wasting time. Okay. And let's deal with the left main. This is a mid-LAD lesion. Let's get on with the left main. So I rotablated into the LAD at that time. And then had some discussion, just tested that we'd got reasonable balloon expansion here. And then I used a 3.5 scoring balloon and high pressure balloons in both the LAD, both ostia, as well as the circumflex more distal lesion, and got good balloon expansion. I was quite happy at this point. So I decided to do a DK crush approach here. And this was I think a 3835 synergy stent, which expanded on this view anyway. It looked quite good. It was actually reasonably easy to pass the stent. We did the crush, and we did a first kiss just with small 3.0 balloons, new balloons, just to get the stent into the right shape. And then we went to position the LAD stent, of course, the LAD. So just a short wire in the LAD to position another 3.5 synergy stent in the LAD to the left main ostium. And then opened the side struts again. It was fairly possible at that stage, and used a 4.0 balloon here to high pressure inflate the ostium, as well as the LAD ostium, as well as a kiss. And then we did a final pot with a 4.5 and then a 5.0 balloon. And this was the result. You can still see some stent distortion here in the one view. I gently tried to get a volcano IVUS catheter down, and there was a lot of resistance, and I decided that that was not going to be fiddled with any further. But I was happy with the result in the left main bifurcation, and we had good flow everywhere. In fact, even in the mid-LAD, we had good flow. So that was the end of the case. I'd love to hear your comments on the management strategy, what I should have done differently.
Mm-hmm. Anybody want to make a comment?
I thought it was an excellent case. Very difficult.
Yeah, it's a great case, David. And I agree with Eric in a sense that there's some profile with the lithotripsy balloons. And sometimes you have to rotor and then still shockwave some of the cases because it's so hard to get things across. So despite them not being available, you did a great job. Rotor still is a front cut device, and I think it worked very well. Of course, these days we'll err on imaging everything as well to make sure that it well expanded in these, particularly since you're a school teacher, make sure they do a good job. But God's watching for that one.
Yeah, Sidney, I mean, I agree with you. My thoughts were that if I had lithotripsy available, maybe after the rotor with a 175 burr as well as a predilatation, maybe I'd been able to get a lithotripsy balloon down, and that would have certainly helped us in the in the ostia both sides, as well as that circumflex lesion, which was incredibly resistant.
You know, concerning lithotripsy, you know, I had a case, I don't have it here on file, but one of our first cases was a very calcified but, you know, large LAD. So the issue was not to get the lithotripsy balloon down, but it was a long segment, and you are allowed to do 10 bursts. So you have to, you know, see where you put this burst because you don't have the whole thing. So we did quite some bursts distally, less, quite some bursts, maybe not enough bursts distally, a lot more proximally because we thought there was more calcification also on IVUS, and we were unable to crack the calcium. And we were even unable to crack the calcium with the OPN balloon. And finally stented it and finally reballooned it. And we couldn't get our MLA above 5. So maybe it's not so bad, but that indicates that lithotripsy is not also the golden solution. So I think, you know, it's only one case, of course, and it doesn't mean a lot, but I think we are learning this technique, and probably you need to do enough burst at the site to really crack the calcium. Certainly when it's really circumferential deep calcium. I don't know if everybody else has an experience with that.
So there's been some failures and aortosteal lesions or in-stent calcification or if they're extremely thick calcium. I think sometimes some cases have been rotated before and still failed. I agree with Eric. I think sometimes you need more pulses. The peripheral balloons have more pulses available on the machines. You know, there's 8 × 10 treatments. So there's 80 pulses available in your one coronary balloon. But actually, there's an override machine. But that's not. I think for commercial reasons, they have to limit that balloon to 80 pulses. But actually, the balloon can be overwritten. We've tried a few for some experiments, and you can actually override the balloon and shock as much as you want.
Really?
Yes, you can until it breaks.
Did anything else? Yeah, sorry, I'll let you finish, Sidney.
Yeah, no. Just the thing was, I was speaking to Zhe ZHAO Ali, and he did the preclinical stuff, and the FDA mandated sub-analysis, OCT sub-analysis in all the disrupt trials because they saw some vessel hematoma, and I think the company limited the number of pulses available in coronary balloon because they don't know, they don't really know. Yeah.
Has anyone done rotablation with 2 wires in place using a microcatheter to protect the non-rotor wire? I saw a case presented once, but I've never done that myself.
You've got to be distal, though. I think what it means that your whole system has to be distal.
Did anybody see
in the sheath on a rotor is not going to really wrap in your other wire, but that's because you have rotated through you know, STL1 or mother and child guideline as well, just to not touch anything proximally. But yeah, got to be just distal, separate it basically.
Okay. So we proceed for next case from Australia.
Did anybody see some patients with chest pain after shockwave? Have some patients with unexplained chest pain, no ECG changes, no troponin rise for hours? No, I don't know.
I had quite some hematomas. I mean, just as Sidney was describing.
For my experience, that if you want to short the left main, you must put a wire in circumflex. Sometimes we have 2 cases: short the left main AD and then close the circumflex because of dissection.
So that was a thing in New Zealand that we know because they had the balloon before us, and they said they put a wire down the branches because I think when you crack it, it just can be uncontrollable, crack down the calcified planes and cause side branches, particularly big ones, to go out. So now we will do that as well, is to put a wire down a big side branch close to where you're shocking in case it went down during the shock wave.
Okay, we need to go on with the next speaker.
So that would be me, I guess.
Yeah. So we're going all the way to Australia. Bernhard KUEPPER.
Let me see whether we get that. Unfortunately, it doesn't show. Edmund, do you have the presentation? Okay. Just to set the scene, I'm the odd one out. I'm non-interventional. Alice Springs is serving the center of Australia, which is 873,000 square kilometers. And we have 1 hospital, and we're looking after 48,000 people, and 43% of these people are Aboriginals. But this lady here was a Caucasian. Can you go to the next slide? Probably, yeah, thank you. So it's a little bit of a torturous path, and it's an interesting learning case, nevertheless. This lady is 70 years of age last year, and she had a history of typical symptoms with shortness of breath and chest pain, a positive exercise stress echo, and underwent an angiography earlier that year, which showed minor coronary artery disease with a 20% LAD lesion and a 30% circumflex lesion, and normal left ventricular function, and had a background of anxiety, hypertension, and hypothyroidism. She was on appropriate medication, and she had pre-existingly a left Barner branch block. Can you go to the next slide, please? On this day in May last year, she drove herself to the hospital with diarrhea and vomiting since about midnight. She had some pain in her abdomen and shoulder and back, but no left-sided chest pain and nothing in the ECG except for the left Barner branch block. Her observations were a little bit hypertensive and her blood glucose level was elevated, which wasn't known before. Can you go to the next slide, please? The ECG did show a left Barner branch block with mild elevations in V1 and V2. There was one ectopic bead, and it didn't really differentiate much from the ECGs which were recorded previously. Next slide, please. The cause was that she had olfactory nauseation and a couple of vomits. And then around the midday mark, she started getting an oxygen requirement. She had to have a breather mask. She got short of breath with increased work of breathing. She showed that she was quite hypertensive and tachycardic, 140 beats per minute and 170 over 100 millimeters Hg, was very anxious, diaphoretic, and needed BiPAP. She was reviewed and there was a discordant ST elevation of more than 5 millimeters in leads V4 and V5. And a bedside echocardiography was requested and done. And the ED consultant concluded together with the echotech that they felt it looked like a Takotsubo cardiomyopathy. The decision was made not to thrombolize at this time. Can you click twice, please? And again, so that's the ECG. And when you remember the other ECG, you do see that there are some ST elevations which are new in V2 and V3 compared to the other ECG. Go to the next one, please. The whole scenario continued with involvement of different services in the hospital, including the intensive care colleagues. And because the patient didn't really stabilize, the patient was shifted to the intensive care ward at 10 o'clock in the evening. Next slide, please. There were discussions with our referral hospital, and cardiothoracic surgery is only available in Adelaide, not in Darwin. Both hospitals have about the same distance of 1,500 kilometers. And usually one flight from the Royal Flying Doctor Service leaves around 7 o'clock in the morning. If we send another plane during the day, we will not be able to retrieve patients from that vast territory who need to come to the hospital. So the decision has to be made whether a patient gets accepted and would go for an angiography. The troponin at this stage at 20 minutes to 8 in the evening was 18,813 with the diagnosis of, or the working diagnosis of a Takotsubo cardiomyopathy and the angiography which was done in January. It was decided to watch and wait and see whether everything would improve the next day. The patient was put on the appropriate medication and put onto the monitor. Next slide, please. One of the pitfalls here was that at the time, the preliminary echo report could be seen by everybody and could be taken for that the cardiologist already signed it off, which he didn't see it. And when the cardiologist signed it off, he actually changed it from Takotsubo to ischemic change of the left ventricle. Next slide, please. The patient was discussed again, particularly in the light of a troponin rise to more than 50,000. Consecutive measurements stayed the same. But only accepted after the patient developed a complete heart block. Next slide, please. The patient needed recurrent resuscitation and a temporary pacing wire. Next slide, please. And was then flown to Adelaide and taken into the cath lab. First, the pacemaker was implanted and then the angiography was done, and it showed that a laminar thrombus requiring warfarin with bridging enoxaparin had built up, and this was stented. Next slide, please. At that stage, there was a significant loss of left ventricular function. It was moderate to severely impaired with an ejection fraction of 30%. Next slide, please. This is just summarizing the Takotsubo cardiomyopathy, which you usually diagnose with the levocardiography, but I think you can make that call in an echocardiography as well. Next slide, please. This would be what you expect to see. And the next slide, please. But you would find open coronary arteries, which in this case wasn't really the finding. Next slide, please. You can use the ECG, but the problem with that is the sensitivity, if you use Garbosa criteria, is limited to 36%. With that, it's giving you a hint, but you have to make a call, and the call which we can only do in Alice Springs would be to go for a thrombolysis. And the patient presented with diarrhea and vomiting and had that repetitively. Next slide, please. Then you have the modified criteria. Next slide, please. And this is what you would expect to see in the ECG. This is just a recap of the ECG changes. Next slide, please. The points which we came across when we did the root cause analysis, because the patient did have a persistent impaired left ventricular function with recurrent pulmonary edema after treatment, and went down to Adelaide again after she was discharged from the hospital. She elected to not follow the advice to take it easy, but she walked 4 or 5 blocks and then was admitted with a pulmonary edema again. The re-angiography did show that the stent was open and nothing had changed in the coronary arteries. So the patient presented with possibly infectious picture of diarrhea and vomiting, but that changed and was not the severe problem the patient had, particularly in female, old people and diabetics. Her first blood sugar was really elevated. The picture can be misleading. Troponin levels were too high for Takotsubo. There are multiple publications which say when you have such a high troponin, you should not think of Takotsubo. A pre-existing angiography with a low level of disease does not preclude a plaque rupture and a STEMI. A plaque rupture is more likely in an inflammatory state, like she had diarrhea and vomiting. If we wait with the decision, we lose muscle. And preliminary echo reports can be misleading, particularly if the working diagnosis in the echo report is taken through several stages and never revised. When everybody stays with a Takotsubo cardiomyopathy and the patient then has a delayed treatment. Next slide, please. Thank you very much, and I hope you enjoyed that different case.
Very much. That was really nice. Takotsubo is a challenge. I have a question for you, maybe for everybody. We started to talk about Takotsubo only about 15 years ago, more or less. And you know, it was first documented, as everybody knows, in the Far East, and you know the story. And then basically it was picked up after the tube publication in New England a journal, where our American colleagues pointed out what was stress-induced cardiomyopathy. But we knew it before about this entity, at least in Europe and maybe also in your regions. But why didn't we talk about Takotsubo in the 90s? Because it was also certainly around. And we see this typically with older ladies after an emotional issue. It's such a typical thing, and we see every week we see Takotsubos in our practice. And so I wonder what you think about it, because I have the impression that there were Takotsubos in the 90s, but why didn't we diagnose these patients, or was it something else? Anybody has an idea?
The primary PCI service we didn't have, Eric. Once you do primary PCI, it all go to the cath lab pretty much, because they look sick, they got ST changes, and then you say the currents are normal. So then it becomes like nothing to stent.
You know, I'm here in Lausanne since '91. We did primary PCI already in the early 90s. You know, like the Dutch people did. But you know, we didn't see. I don't know. We didn't see Takotsubos. Or maybe some people thought it was, you know, like spontaneous lysis of the coronary. You know, people didn't know what it was.
Yeah.
But I know, Dave, you're also a senior guy. What is the situation in South Africa? You know, in the 90s.
Yeah, you know, I think we used to. You know, I remember looking back at old series when I first started doing angioplasty for patients at MI maybe 20 years ago, and we would see cases that we had diagnosed as an anteroseptal myocardial infarction with antroapical hypokinesia, and then we did the angiogram and the coronaries were normal, and then we would say, okay, spontaneous reperfusion, don't know where to put the stent, haven't identified. You know, we weren't doing the intracoronary imaging, so we said, well, you know, angiogram is very insensitive for showing plaque rupture. And I think Sidney's right. I think we just didn't pick up the pattern because we saw them as anteroseptal MI variants. I think the vast majority, I would say. There's no doubt that when somebody said, there's a Takotsubo, the penny dropped for all of us, I think.
Yeah. So Bernhard, what's your experience in Alice Springs? Have you seen Takotsubos in the 90s, or?
I would say that we probably didn't look for it. In the 90s, one of the approaches was when you did see that the ventricle was dilated and not really working, that you probably wouldn't necessarily do an urgent angiography. And I'm not so sure how the follow-up was, whether it was then noted that the left ventricular function improved quickly. And somewhere along the line, people realized there is something happening, which is a pattern. I think it was probably somewhere under the anteroseptal myocardial infarction. As said, where you do an angiography, the vessel is open, and you think there's a spontaneous recanalization of the vessel. But I don't think we put one and one together and did see it as an entity as such. And what I did read about that is basically it does have a negative prognostic meaning for the patient, because they are likely to have this pattern again. And they may have a shortened lifespan with just seeing it for the first time.
We have seen atypical forms, you know, inferior Takotsubos, we have right-sided Takotsubos.
Very popular in Japan. That's why it's called Takotsubo.
You know, Eric, your comments make me recall that quite recently I saw a patient that I've been following up for 20 years, and I went back into her notes, and I saw in my old handwritten notes that have now been scanned onto the electronic system, unusual recovery of LV function, no residual LV dysfunction noted, you know, and realized at the time, okay, it was a Takotsubo, you idiot. So yeah, I mean, they were there, we saw them, we didn't know about them.
You know that, it was only unless after it was published in New England that our American colleagues accepted. Basically, our Japanese and European colleagues tried to publish on it, but they were just, you know, considered as, you know, as rubbish, you know. They couldn't get it published. It was only unless our American colleagues discovered stress-induced that it was.
Maybe we should go for next case. For Takotsubo, I tell you, in my experience, most challenging is diagnose reverse Takotsubo. I just see it once in my life.
Maybe just there is a small comment because I see Jack appearing. Jack, you want to say something shortly?
Sorry for coming in late. I was still on call this week, but my center started acute PCI in 98. It was never called Takotsubo. If I look at the old notes, they were labeled as either recanalized or vasospasm in these ladies. With the MI, with the regional wall, they were called coronary vasospasm. And that was the most common diagnosis for Takotsubos in those days for my side.
Okay, we need to go on.
Vinci from Italy, yes.
Okay,
Ciao to everybody from Italy. So let's see if I manage to share my screen.
We see some nice bottles in the back. What is
Say
that?
it's an open system and privacy. Oh my God, that's always same.
The funny thing is,
we will probably. Okay, so I think I need to disconnect from Zoom and reconnect in a moment. Bear with me, 2 seconds.
Okay. Well, then I will briefly, if you want, tell my story I started because it's a funny case. I can just tell you about my complication I had yesterday. If that's okay. It's very short.
Yeah, sure.
Okay, very quickly. So the lady is 32 years old, and she's very famous in the region. She's basically a very well-known chef, cook, and she's very well-known. So on Tuesday, she had a cryptogenic stroke, PFO, and Tuesday close to PFO. She's very stressed. Also during the procedure, she was very worried, but everything went fine. We put in a GOR 25, good result. During intervention, she was very, when we do this with intracardiac echo, local anesthesia in the outpatient clinic, but moving up the intracardiac echo probe, putting the device in, she felt pain in the heart region. She was very sensitive. But anyway, she went home the same day, and the next day she called me because on Wednesday, the day after, she had 39 degrees of temperature, and she had chest pain that was, inspiration-dependent chest pain. And she had more pain when she was laying down, less pain was sitting up. So it looked a little bit like pericardial irritation. And by the time she called me, she said, "Now I'm no longer, I don't have any more fever, and I'm fine, so I'm okay. I will stay there." So I said, it's maybe better to come over. She said, no, it's okay. So on Thursday, the next day, she called me back because she had fever again on Wednesday evening, 39. I said, shouldn't you do a COVID strike? And no need. So that was Thursday. Everything was, it was better. And then Friday, yesterday morning, I got a phone call from him, totally panicked. And she said, it's terrible. I have so much chest pain. I can't breathe anymore. Every time I breathe in, I have terrible chest pain. The only thing I can do is just hold like this and then it's better. No more fever. And I tell her, okay, now I want you to come to the hospital. So she came to the hospital. I saw her. She was not doing well. I first did an echo. Echo didn't show any pericardial effusion. The device was nicely in place. I did an X-ray that was normal, no pneumothorax, nothing. I considered doing a CT scan. DCG was normal too. So I didn't understand basically what was going on. So I called the infectious disease guys in and they saw her. So I didn't really know. I called the GOR people. I say, I have a case of fever after a GOR implant. We have a 0.8 incidence of fever after this implant. But I've never seen that. I'm closing PFO since 2008. I've never seen that. I've seen a case of fever, but so I really didn't know what to do. So, well, we got the diagnosis yesterday evening, and basically she was COVID positive. So that was it. So it was a clinical picture of pericarditis, reactive pericarditis after PFO closure. and basically she simply had COVID. She was basically, her main complaint was chest pain, pericardial chest pain, after implanting a PFO device.
So are you in isolation now? You're close contact.
No, I had really close contact with her, yeah.
So did you do the case in PPE or in normal attire?
I didn't perform the usual protective measures, so I may be infected, yeah.
Do you think that the stroke could have been COVID related? Or was it too
the stroke was
So that reminds me about your coronary complication course. Instead of 3 C's, we should have 4 C's. COVID coronary complication course.
Okay.
So I'll let you know
I should be fine now.
Okay. Yes. Viceno, yeah, please share your case.
Hello.
So,
hey.
Here we go. Can you see?
Yes.
Excellent. I am actually glad because sorry, can someone mute his microphones? All right. So I'm actually glad to show this case because it's very similar to the one Dr. Ishihara showed earlier on. So it's a case of a 75-year-old man who had a history of angina, worsening angina in the last 3 months, a positive treadmill test, preserved the LV ejection fraction on echo, no significant comorbidities apart of rheumatoid arthritis. So he's got single vessel coronary artery disease involving the proximal LAD at the bifurcation with a good sized diagonal branch. So I classify this lesion as a Medina 111, and I plan to do an angioplasty with provisional stenting. So right radial approach, 6-branch guide, 2 workhorse wires in the LAD and the diagonal. So I pre-dilated with a 2.5 balloon. I put a 3.0 by 23 sirolimus eluting stent, and I potted with a 3.5 short NC balloon just before the carina. So here we go with the first problem. So I had no flow in the diagonal branch, and I tried to rewire it, but likely causing a dissection. So at that point, the patient had chest pain. The ST was up on monitor. So I had to do a bailout strategy. So I inflated a 1.25 balloon over the jail wire. So in order to gain again flow in the diagonal branch, settle patients' symptoms, and had more time to rewire the diagonal. And actually, this is what I managed to do. Please let me specify that I wired the diagonal with the LAD wire, which was never pulled out of the proximal part of the stent. So I did pot again and another dilatation at the level of the distal stent, because I knew that after having dilated with a 1.25 over the jade wire, I could have a distortion of the proximal part of the stent. So I tried now to put second stent into the diagonal branch with a tap technique, but I couldn't advance it. And while I tried to remove the stent and the balloon, I felt that dreadful resistance. And I realized that my stent was stuck just at the proximal beat, or anyway, somewhere at the level of the ostial LAD. So the wire was in. The stent, differently from the case showed earlier on, was inside the guiding catheter. So what I tried to do was to advance a very small balloon to inflate and remove the stent, but it was not possible. I tried to do the same with the guideliner support, but again, it was not possible. So I did what it was suggested earlier on. So I trapped the stent into the guiding catheter, and I had the longest 5 seconds of my life in this case. As you can see, I just remove everything. So, but now I had the third problem. So I had a stent inserted into the LAD, which probably was not the main problem at the moment. I had a dissected diagonal branch. I had something in the proximal LAD, likely a distorted stent, but most importantly, I didn't have any wires there. So I managed to wire the stent again, but nothing passed over the proximal bit of the stent in the proximal LAD. So I thought that I might be outside the stent struts, and what I tried to do was to put a short tip IVUS catheter just in the proximal edge of the stent and trying to rewire the stent inside. You can already see that here the stent was completely distorted, and here it's me with my wire trying to rewire inside it. But I didn't manage to do it because everything I tried to advance with the wire didn't pass. So eventually a Corsair did the job. So I made room into the piece of metal, which I think it cannot be called stent anymore at that point. So I dilated with increasingly higher size balloon, and I managed to put an IVUS up to the distal part of the LAD. So this is what I was actually expecting. So the distal part of the stent was perfectly fine. The wire was inside of it. Same thing at the carina, but just an proximal bit of the part of the stent in the proximal LAD, I had the wire outside the stent and the stent completely distorted. So that was basically the situation. And what I decided therefore to do was to crush the proximal bit or the proximal part of the stent with another stent. And this is what I did. So I used a self-expanding drug-eluting stent from the carina up to the ostium of the left wing. Then I opened the struts into the circumflex. And that was the result. The result, which was very nice at the IVUS as well. As you can see, the stent was roundly expanded everywhere. And after that, I managed to rewire the diagonal. Probably there was a changing in the port and putting the second stent proximally. And I managed to put a third drug-eluting stent with a tap technique with a lovely angiographic result. So patient was discharged 48 hours later with a DAPT long life. He didn't develop any nephropathy despite a very high dose of contrast that I used. And after 3 months, we decided to bring him back to do a follow-up, an angiographic follow-up, which was great. So I think that these cases show that bifurcation PCI can be considered a complex procedure. And when a complications occurs, you need to know what equipment to use to get out of the problem. And in this case, intravascular imaging, as usual, gives you a lot of information that can be really helpful to fix the issues. So thank you.
Thank you very much. That was a short, great case showing the complication that can occur. It's always tricky to know how much you can push and pull when you're suffering with stents, and which is the threshold to think that maybe you shouldn't force too much. It's not easy. Huh? Not easy. Any comments, questions?
Why did you go for a self-expanding stent as opposed to a regular drug-eluting stent?
Well, actually, there was no particular reason. The feeling was that I didn't see any significant disease in the left main. There was no calcium throughout. So I thought that just having a stent that kept going, is expanding and remodeling into the proximal part of the LAD and the left main would have been fine. But I don't think that made any difference. A normal drug-eluting stent would have done the same. Absolutely.
Vince, I'm Yongcheol.
Hi.
Yeah, hey. I have one question. Is that did you plan your strategy for this bifurcation region with just a single crossover?
Yes, the initial strategy was to do just a provisional stent. So just a very 5 minutes procedure, stent across the diagonal, kissing balloon, pot, and that's it. But
yeah,
not the case.
So nowadays is I got several cases of bifurcation 2 bifurcation region Medina 111. So now I prefer the jailed corsair wire corsair technique or jailed balloon technique to protect side branch. I think is that the particular case is really suitable for the is a jailed corsair or jailed balloon technique. What do you think that?
I think it's a very promising technique. I read a lot of case reports and CHIPCase series published about that. The only issue with that is that I think that all the problem came when I basically inflated the balloon over the jade wire. So I have distorted the proximal bit of the stent. So in the jailed balloon technique, my personal fear, but obviously I've never done that, so it might be the contrary, is exactly that problem, that if you leave the jailed balloon there, you might have issues. Then you need to be definitely sure that you do a proper pot after having done that. But I have no experience with this technique.
Yeah, it's normally a true left main bifurcation, including the ostial lesion of the side branch. So it's normally just the jailed wire would be okay. But nowadays I suffered several cases jailed side branch after crossover stenting in the true bifurcation region. So jailed wire is a jailed balloon or jailed corsair have is a big advantage. Number one is we can keep this ostial side branch widening. That is more easy to the rewiring chance.
Yes, and Dr. Kim.
Yeah.
Yes, I can agree with. I also agree with you. So I usually use jailed balloon and jailed corsair. So for this case, jailed balloon is better because the vessel is enough to put stent. If the side branch is important but not so large, at that time I do jailed corsair technique. So both techniques so similar, but very nice. But if the side branch is enough large, jailed balloon is better.
Maybe we can listen to Zhang Bin, because Zhang Bin, he writes, jailed balloon is useless. Maybe you can explain yourself. Where are you? Zhang Bin, where are you?
Zhang Bin.
I'm sorry?
No. From his bedroom. Very nice day.
Champion is, I think the.
I think. Sorry.
there you are. Yeah.
Because this kind of situation, we just use a wire to protect it. If it is corroded, we can rewire it very easily. So I think jailed balloon, I don't think it's useful. So if you use some hydrophilic wire, you can cross it very easily. So I don't think it's useful.
Yeah, but not everybody has your skills. Your
So so Eric, isn't the issue when does a JAIO balloon technique turn into a trap balloon problem?
Yeah.
And I think if you don't know that thing, then we wouldn't do it. So we don't do it because we don't know how often it's going to be a big problem when the balloon's trapped.
But if we
also, sorry, and also we need to take into account that if I tell my administrators that I've used a corsair to protect a side branch, they will kill me or fire me. So, it's a matter of cost.
Same problem I have. Yeah.
Okay, I think we need to, Merida, I think your case is lost, huh?
I think we have to conclude and
conclude.
Yes.
No problem. But I hope next meeting I can present.
Next time.
We're looking forward to it.
So
Yes.
who's going to make the concluding remarks?
Yes, maybe Jack.
If you can do that.
And Dr. Lu.
Far south.
It's been very informative. Thank you very much for the case presenters. That was very amazing. Really.
Indeed, indeed. Who wants to conclude?
Maybe we should take a photo together. Let me take say cheese and then yes.
Take a photo together. How are you doing that?
Yes.
We can do a screenshot.
Yes.
If everybody is smiling, then we can have it. I just count 3, 2, 1.
Yes. Cheese. And then we'll send back the pictures to everyone.
I will send it around. I will send it around. Thanks for sharing all your cases and the presentation. And it's always glad to meet new friends and have new insights. To have these fantastic insights into the healthcare system, different countries, and how you deal with the problems that we encounter. I certainly learned a lot, and I'm looking forward to the next case session and maybe another 6 continents session. And thanks, Lam, for the organization, and Anshul for all your insights, and, for the moderators and the case presenters. And next time, Merida, this will be your case. Thanks for having us. Thanks for coming, and thanks. Have a great weekend.